Our next paper is, again, Dr. Eustina Kwon from Seattle, and this time shifting gears to looking at gun violence. Her paper is titled Social Vulnerability Index, a valuable tool to identify youth at high risk for gun violence.
Thank you again for the privilege of presenting today. My name is Eustina Kwon, Research Fellow at the University of Washington and Seattle Children's Hospital. I'm excited to be presenting our project, which we have been working on in collaboration with Harborview Medical Center, titled Social Vulnerability Index, a valuable tool to identify youth at high risk for gun violence. We have nothing to disclose. Social determinants of health and community-level factors can have a profound impact on the well-being of a child. Injury is common in the pediatric age group, and a child's experience with injury may be impacted by their community of residence. In this study, we aim to better define the relationship between community-level social vulnerability, as measured by Social Vulnerability Index, and pediatric trauma mechanism type and outcomes. Harborview Medical Center is the only Level 1 pediatric trauma center in the state of Washington. The institutional trauma registry was used to identify all injured pediatric patients cared for at our center over a 10-year period. Out-of-state patients were excluded. Social Vulnerability Index, or SVI, was built by the CDC to capture the potential impact on the community caused by the aggregate of demographic, social, and socioeconomic factors. The indices are reported by a composite score, as well as 4 subcategories: socioeconomic status, household composition and disability, minority status and language, and housing type and transportation. We identified a total of 5,495 injured children. Basic demographics of the cohort are seen here. The average age was 9 years, with approximately 2/3 being male and 2/3 being white. 11% were Black and 17% identified as Hispanic or Latino ethnicity. 53% of patients had public insurance. SVI represents percentile ranking of relative vulnerability of each census tract. For example, a score of 75th percentile indicates that a census tract is more vulnerable than 75% and less vulnerable than 25% of the census tracts in that state. For our analysis, we utilized census tract level SVI to calculate weighted SVI by zip code in the state of Washington. With regard to composite SVI, there was a pretty even distribution by quartile in our cohort. 16% had a composite score less than the 25th percentile, and 22% had a score greater than 75th percentile. When looking at patient characteristics by SVI percentile category, there was a stepwise increase in Black race, Hispanic or Latino ethnicity, and public insurance status as the composite SVI increased. There was also a stepwise increase in the proportion of patients injured by a firearm with increasing SVI. For those living in a community with SVI above the 75th percentile, almost 10% of all pediatric injuries were due to a firearm. Lastly, there was a trend towards higher mortality while in hospital with increasing SVI. Given firearm injuries were most common in the adolescent age group, we performed a multinomial logistic regression analysis on a subgroup of adolescents aged 13 or older to determine factors associated with an increased risk of firearm injury. Adolescents who were male, Black, or African American, and those with substance use disorder or Medicaid insurance were significantly more likely to present with gun-related injuries compared to motor vehicle or motorcycle crash. It is important to note that 75% of pediatric firearm injuries occurred amongst children living in a community with a composite SVI greater than 50th percentile. When looking at SVI, we found that for adolescents, every 10th percentile increase in composite SVI was associated with an 11% higher chance of injury due to guns compared to MVC or motorcycle crash. In conclusion, we found that pediatric injury mechanisms differ by community-level social vulnerability. communities with the highest SVI experience a disproportionate number of pediatric firearm injuries. And based on these findings, we believe that SVI may be a valuable tool for targeting community-based violence prevention efforts. Thank you.
This paper is open for discussion. Dr. Gaines?
It was really nicely presented. Thank you for bringing that to us. I was wondering if you looked at the difference between low SVI in an urban area versus a rural area, because I think that perhaps your interventions might be different in those two different types of areas.
Yeah, thank you for that question. When we mapped out the SVI based on the zip code through the state of Washington, there are certainly clusters of higher vulnerability, vulnerable zip codes versus lower vulnerability. And although there are urban areas with higher vulnerability, there are zip codes that are adjacent to one another in terms of very low vulnerability zip codes right next to those with high vulnerability, even in urban or rural areas. We didn't specifically take to account the urban versus rural factor, but I think the SVI is a very complex metric that encompasses a lot of those community level factors.
Along those same lines, are there any data to suggest? Along those same lines, are there any data to correlate gun prevalence or availability that might be correlated to SVI? Meaning, are there more guns in areas with higher SVI, or is there some other factor? I suspect that's probably a multifactorial issue, but are there data about that?
We didn't specifically look at the availability of guns in relation to the gun-related injuries and prevalence of it, but that's certainly one thing that we can look into for future study.
Okay, thank you.
Thank you.